Hey guys, welcome back to All on Law. In this video, I'm going to talk about TTNB, or even you can call as a TNB, the transient tachypnea of newborn. Transient tachypnea of newborn. This is a simple topic. It's a benign disease and very important too. Very important for examination also. So let's go ahead with this. The transient tachypnea of newborn, that is a TTNB or a TTN, was first described by Avery and his co-workers in 1966. The reason is that the fetal lung, that is the lung of a fetus in during intrauterine life, doesn't take part in the oxygenating the blood. That's why this lung is filled with a fluid, right? So lungs are filled with the fluid because they don't take part in the oxygenation. These are the pulmonary arteries, so no oxygenation here. Now as soon as the baby cries, and the air gushes in and the fluid starts coming out of this, so lungs has to be cleared from this fluid. The fluid should be absorbed, and as a result, what happens, the baby starts to breathe and there will be oxygenation of the blood from the lungs. Before that, it's a placenta which is purifying the blood. Here now lungs take over. Okay, so it's a TTNB is a benign self-limited process. It generally affects the infants born at a late preterm. Who are late preterm is nothing but 34 to 36 plus 6 week. The normal is 37 to 40 weeks, right? So less than 37 is a preterm. In that, late preterm is 34 to 36 plus 6, whereas early preterm will be lesser than this, 34 weeker, right? This disorder is characterized by tachypnea, there is an increase in the respiratory rate, and the signs of mild respiratory distress, including the retraction and the cyanosis. Cyanosis. Okay, and sometimes the babies might require oxygen support with a FiO2 of less than 0.04%. Okay, or 40% you can call. Let's talk about the pathophysiology of the TTNB, or a transient tachypnea of newborn. As we know that, as I said, that when the newborn breathes, this is the lungs. Okay, as the air comes in, okay, it goes into the lungs and starts pushing the fluid from the lungs. So there are different channels that helps, and there are different hormones that helps in the clearance of the lung. Okay, so the transient, what you call change, is really very important. The hormones that helps in the clearance are glucocorticoids, and catecholamines. So remember these two important things, because they tried treating TTNB with this, but it wasn't successful. Though it is deficient in a patient or in a newborn who is having TTNB, it's not complete deficient. Usually, when the baby is born, these hormones helps in the clearing the what you call lung filled with a fluid. Okay. So the other thing is that the channels, there is a, what you call the channels known as amyloid sensitive sodium channels expressed in the apical membranes of alveolar epithelium. Okay, they also help in the lung clearance. Even the adrenergic stimulation and other, what are the changes that takes place during the near the third trimester birth is really very important. And another one channel, that is Na plus sodium plus potassium ATPase channel, and that also helps. And even the passive movement of chloride and water through paracellular and intracellular pathways. So these are the changes: the hormones, that's the glucocorticoids, catecholamines, the channels, amyloid sodium channels, and sodium and potassium ATPase channel. Okay, what happens? The interstitial lung fluid pools in the perivascular cuffs of a tissue and in the interlobar fissures, and is then cleared into the pulmonary capillaries and lung lymphatics. So lung lymphatic it goes ultimately. So this is how the fluid is cleared from the lung. The fetal lung is filled with the fluid, so it has to be cleared. So that this process takes place near the term. So those babies born before the term will have this. It doesn't mean that every preterm will have, but it also doesn't mean that every term won't have. So they can develop. It all depends how fast he can clear the fluid from the lungs. That is the basic things. Okay. So there are problems can occur due to this also. Now let's move on to the next, epidemiology. What are the risk factors in which patients or in which newborns you should think of a TTNB or a TTN? One, the baby is a late preterm, that is a 34 to 36 plus 6 weeker, undergoing a section, cesarean section, okay, with or without labor, then precipitous labor and a preterm delivery. Okay, infants who are delivered by elective cesarean section, the presence of labor and a gestational age at the delivery impacts the risk of respiratory complications. Remember, very important. Okay, so it's really very important to diagnose the TTNB, because there are differential diagnoses which can present, because this is a newborn just now, it has presented with a mild respiratory disease. Either it could be a pneumonia, it could be RDS, because the treatment is totally different. That's why the history is really very important. The other risk factors which does not contribute much, but there are risk factors like a male gender. Remember, even RDS male genders are more prone to have this, and a family history of asthma, especially in the mother. Okay, so these are really very important. Remember, the genetic cause, as one more genetic cause, they have found that even beta adrenergic, I forgot to tell you that beta adrenergic receptors and alveolar type 2 cells have been associated with the TTNB. So beta adrenergic receptors on alveolar type 2. Okay. Well, coming to the risk factors, male gender, asthma in the mother, and 3M. Remember the 3M in the babies you can suspect. One is a macrosomia, to the big baby, a maternal diabetes. So in nursery you often see that, and a mother if there is a multiple gestation. Okay, and very less risk factors such as a maternal sedation, if mother is on a maternal sedation, prolonged labor, prolonged labor. Okay, So remember, this is very less. These two are very less. Now, clinical features. Just imagine a newborn is born. A newborn is born. Okay. What are the things? The lungs are still with the fluid. It slowly starts to disappear. So the first thing what you need to see is they will have a respiratory distress. Okay, respiratory distress in the mean of tachypnea. Okay, tachypnea. The respiratory rate usually in the newborns is 40 to 60 cycles per minute. In tachypnea, increased respiratory rate, it can go up to 120. Usually in the newborn nursery, you see around 70 to 80, but yet it can go to 120 breaths per minute. At the same time, you can notice some retractions, subcostal retraction, okay, or intercostal retractions. Grunting can be seen. A pronounced sound you can see over here they produce, like okay. Nasal flaring. Okay, and even sometimes you can see a cyanosis. Remember, and usually they respond well. If you check the saturations, it will be a lesser than 90%, and if you give oxygen, it really helps. Supplemental oxygen really helps. And these babies rarely, very rarely require mechanical ventilation. Remember, okay. So if you look at the chest, so what happens, there will be the increased anterior posterior diameter of the chest. It becomes a barrel shaped due to hyperinflation. The baby is breathing and the lungs are filled with the fluid. So what happens, the lungs becomes hyperinflated, and this hyperinflated can push down the liver and spleen. So what happens on examination, you can find hepatomegaly or a spleen palpable. Not, it's obvious hepatomegaly actually. Okay, if you auscultate on examination, you will see a good air entry and the crackles may or may not be present. This symptom visually starts within 6 hours. Okay, soon after the birth you can notice that 6 hours, not 60, 6 hours, and it usually last for 12 to 24 hours. 12 to 24 hours, but it can go up to 72 hours, 3 days in more severe cases. Remember, you should know the normal range usually. So if you attend the delivery or a section, cesarean section, if you see a newborn with a respiratory rate of around 70 and it's a late preterm and a maternal diabetes is there and he's requiring a few liters of oxygen, he should not be requiring more. Remember this, not more than 40%, and retractions, mild retractions are there, then you can wait and see and reassess after half an hour, 1 hour, and you see the symptoms compared to the previous, what you call previous period. If it's better, then it's a TTNB. If you're in doubt, you can take a chest x-ray. It's rarely required. TTNB child, newborn, will be improving so fast. Okay, give a time for 6 hours, still it's the same, then you can plan and you have the differential diagnosis, which I'm going to tell later, and you can go ahead with the investigations. Now the differential diagnosis for a TTMB will be, the first important thing is RDS, respiratory distress syndrome. If RDS is there, the treatment is totally different, right? Okay, then it could be a pneumonia, congenital pneumonia, it could be a sepsis, it could be a pulmonary hypertension, it could be a meconium aspiration syndrome, it could be a cyanotic heart disease, it could be what you call congenital diaphragmatic hernia and other things. Okay, it could be a pneumothorax, it could be a polycythemia, it could be a metabolic acidosis. Now the important thing over here is try to take a history in detail. The maternal history is really very important, that will help you to diagnose the TTNB. Well, if you take a chest x-ray, you could see the radiological evaluations. The radiological evaluations, as you can suspect here in the lungs, okay, if you take a chest x-ray here, you can see that there will be retained the fetal lung fluid with characteristics prominent perihilar streaking, that is known as a sunburst appearance. Just google the images, you can see over there sunburst appearance or a pattern. What is the cause for this? Is the cause for this is the engorgement of periarterial lymphatics that participate in the clearance of the alveolar fluid, which we discussed in the pathophysiology. The coarse, sometimes you can see the coarse fluffy densities may reflect the alveolar edema. Hyperaeration you can see if you take a chest x-ray, okay, very important. And you should be able to differentiate this after taking a chest x-ray. You should be able to differentiate whether it's a TTNB or RDS. Well, sometimes what happens that sometimes it's a very difficult to differentiate, then it goes along with your clinical symptoms and the maternal history. The intercostal space could be widened, remember this, it could be like this, widened, it could be horizontal. There can be a mild pleural effusion may be observed, okay. So it's really very important to differentiate from other conditions. What are the investigations? No investigations are required, no lab tests are required for to make confirm the diagnosis of TTNB. If it's not there, then you have to do the investigations. CBC, that's a complete blood count, is important, blood culture, to rule out sepsis and a pneumonia, okay. If it doesn't improve, then you can start with the broad spectrum antibiotics. Blood gas is really very important. Now I will give you a scenario, okay. Remember, antibiotics can be started. If it doesn't improve, then take and see the ABG, whether it's respiratory acidosis or hypoxemia is there, okay. If still persistent, cardiac evaluation can be done, right. So very important. Now how would you treat it? What's the treatment? How can I go ahead with the treatment? As I said, it just needs a supplemental oxygen. Oxygen will be very less required. More severe cases, they can require the CPAP, which gives a PEEP. Okay. If you are in doubt, do send for blood culture and start on antibiotics. If tachypnea persists and increase with increased risk of breathing, increased work of breathing, sorry, then what you can do, you can start with the IV fluids. Very important. IV fluids. How much you're going to start? If a term and the preterm. So if it's a preterm, you can start with a 670 ml per kg, 70 to 80, and 60 for a term. So remember one more thing, that it's better to avoid more fluids, because if you give more fluids, it can go into the lungs and cause more discomfort. So on a day one, you can restrict the fluid. Okay. Now, as I said, there are two things. You can clear the lungs. Can we clear the lungs with giving furosemide? Yet they tried it, but it wasn't successful. It wasn't successful. It didn't reduce the duration of tachypnea. It didn't even reduce the length of hospitalization. Even they tried that the Dtmb babies will have a low catecholamines, so they started treating them with a racemic epinephrine, but it also did not help in the improvement of a tachypnea. That's why the most important thing is just give supplemental oxygen, and if more severe, you can go ahead with the CPAP, and IV fluid should be started in view of tachypnea. What are the complications? It's a self-limited, remember, it's self-limited. It's excellent. It's just like a physiology that is extending, that's it. Okay, if you start on a CPAP, then can be complication due to CPAP, that is a ALE, pneumonia, pneumothorax, sorry, can be there, okay. And the one more thing is that if you delay in initiating the oral feeds because of the tachypnea, parental bonding can be decreased, and even the breastfeeding can decrease, okay, remember. Well, how do? They do very well, okay, remember. So for example, if you attend, if you are called to see that you are attending a 35 weeker, and maternal history is the maternal diabetes. Okay, and the baby has a respiratory rate of 70 cycles per minute with mild retraction, requiring 1 liter or 2 liters of oxygen on hood box. Then what do we like to do? Just reassess. If everything is okay, reassess after half an hour and see. If same, continue to reassess after half an hour. Okay, if you're improving, then no need, nothing. You can see once it's oxygen free, he should be maintaining, and you can discharge the baby. You can, shift the baby to the mother side. If it's still the same or it's worsening, then you can give us one more time, 1 more hour, and you can see. Still in doubt, take an X-ray, take an ABG, maybe something hidden, and depending on that, you can go ahead with that. Okay, so this is regarding TTNB. I think it is helpful. Thank you so much, and please do comment and thumb up. Thank you so much for watching this video. Take care.